So good morning, good afternoon, good evening, wherever you are at, and welcome to the Sleep Gan Rounds sponsored by the American Academy of Sleep Medicine Foundation. So today we have Dr. Ashley Curtis who will join us to discuss cognitive exploration of sleep and aging, training and sex-specific insights. So before I introduce our speaker, I'd like to remind you that your audio is muted and your video is off. And we also encourage you to include any questions on this topic for the speaker in the Q&A of the Zoom platform. This webinar is being recorded and will be shared with everyone who registered for the webinar. And this webinar is approved for 0.75 AMA PRA credits. Next slide, please. So the Sleep Grand Rounds aims to feature ASM Foundation funded work that addresses practice gaps in sleep medicine and sleep health. And then per the updated Accreditation Council for Continuing Medical Education Standards for commercial support, the ASM has implemented a process requiring each speaker to disclose and resolve all conflicts of interest with any commercial entity. We have reviewed the disclosures and resolutions and believe that the submitted citations comply with the ACCME standards. The disclosures and resolutions provided by the speaker are included in the slide presentation for the attendees' information. Now allow me to introduce our speaker today. So Dr. Curtis is an assistant professor at the University of South Florida's College of Nursing and leads the Cognition, Aging, Sleep, and Health lab, also known as the CASH lab. Her research delves into the interplay between sleep and cognition in aging populations, exploring how cognitive training affects sleep and cognitive function. With 47 manuscripts and 5 book chapters, she's funded by prestigious institutions like us, the American Academy of Sleep Medicine Foundation, and has had editorial roles at esteemed journals. Dr. Curtis earned her PhD from York University, specializing in brain behavior and cognitive science, and completed a postdoc fellowship at Sunnybrook Research Institute and the University of Missouri's Sleep Research Lab. Today, she will cover her ASM Foundation-funded focus project grants for junior investigators and her Bridge to Success grant projects on cognition, age, sex, and sex-specific insights. So thank you for joining us, Dr. Curtis. I'm going to give you the floor. It's yours.
Great. Thank you so much. Okay. Are we good, Vanessa?
Yes, we are good.
Excellent. Okay. Thank you so much. I don't need to reintroduce myself. Vanessa did a great job. My name is Ashley Curtis. Is this not going? It's not. Oh, there we go. Okay. No COIs besides the support. Thankful to ASM for supporting this the work in this presentation. Okay, so by the end of this, I hope I can achieve a few things for you all. I hope that you will be able to describe the effects of cognitive training on cognition and sleep in older adults with insomnia. I hope that you can also learn to understand and describe sex differences in sleep and cognition in aging adults, and also learn a little bit and describe about sleep-related attentional biases and how this may differ between men and women with and without insomnia. So I'm going to talk about sleep and cognition and aging, kind of a brief overview given the time constraints of this talk. I will talk about cognitive training and present a conceptual model I've been testing for the last few years. I'll present study 1, which is a focus project award on cognitive training. And then I will talk about sex differences in sleep and cognition, and then present study 2, which is sex differences in sleep-related attentional biases. Okay, so why study sleep and cognition and aging? I'm sure you are all here because you're very passionate about this topic. I'm going to present a few statistics for you all. So up to 95% of older adults report cognitive complaints, and these are, self-reported, usually related to everyday type of functioning, and like I said, very, very common in older adults. Up to 50% of older adults experience insomnia complaints. So these are complaints of trouble falling asleep or staying asleep, not necessarily chronic. So in order to meet the criteria for clinical chronic insomnia disorder, you need to experience these complaints 3 times a week, at least 3 months or greater. And it needs to be coupled with daytime dysfunction as well. So when you think about insomnia that way, 12 to 20% of older adults meet that clinical criteria. So the sleep and cognition link, it's been studied for many, many decades. It's established. We do know that insomnia confers a 1.5 greater risk of developing Alzheimer's disease, which is truly alarming. One of the things that we are still trying to figure out is which specific aspect, which sleep parameter, which aspect of sleep health might have the greatest impact on specific cognitive domains. And this is where we've really been delving into this more acutely into the aspects of sleep health. I've been doing this, in my lab for the last few years as well. And what I'm presenting here is kind of an overview of the different parts of sleep health. So you can see there are many different metrics. There's sleep duration or total sleep time. There's sleep onset latency or ability to fall asleep. There's subjective ratings of your sleep quality. There's sleep efficiency. There's your ability to stay asleep, your wake after sleep onset or WASO, early morning awakenings. And we all measure these as sleep researchers. And when you go and look at the literature in terms of the associations between these very specific sleep parameters and cognition, we notice some interesting findings. So when we look at sleep duration, pretty inconsistent. Some studies show no association between total sleep time and cognitive functioning. Some show that the longer you sleep, that's associated with worse functioning, particularly related to verbal memory. And then on the other end, some research shows that short sleep duration is associated with worse cognitive functioning across an array of domains. So there's kind of that inverted U relationship for sleep duration. But again, it does depend on the patient population, and we're still trying to figure this out. In terms of your sleep fragmentation metrics, so the ones that really interrupt that consolidated sleep, so you can think of sleep onset latency, SOL, WASO, early morning awakenings. These findings are a little more consistent. They're associated with worse cognitive functioning across a variety of domains. So research suggests it's associated with sustained attention, verbal knowledge, forgetting, long-term memory, and visual spatial reasoning. So again, worse or longer metrics of these domains are associated with worse cognitive functioning. So I just wanted to introduce that just to kind of prime you in terms of what we'll be talking about today in terms of the specific sleep domains and why I think it's important to really measure these different aspects of sleep health. So now I'm going to change gears and talk about cognitive training. You've probably heard about it in popular culture and in the media. You've definitely heard it being criticized. But what it is a in-person or computerized strategy or game-based task that targets and trains certain mental abilities. So some people call it brain training as well. And what I'm showing here on the right are just different types of commercialized cognitive training. And like I said, they're kind of like a video game, and they're kind of fun and really aim to invest the user into actually participating. And there's different ways of thinking about it. There's unimodal versus multimodal. Unimodal would be just targeting one domain. So maybe you're going in and targeting processing speed, and that's it. Multimodal would be targeting a variety of domains. And research suggests that when you do that, you actually get greater impact on cognition. There's also this distinction based on how adaptive your cognitive training is. So as with any type of training, you can't plateau, right? You need to keep people engaged. So with cognitive training, you want to make it more difficult so that they are engaged. And that's also associated with more greater impact on cognition. So there's this distinction between near and far transfer. And this is what is debated in the literature. So there are very inconsistent benefits in terms of how much impact you're actually getting on things that are highly related to the game, that near transfer, and the far transfer. So things like sleep, things like other areas of cognition that you're not necessarily targeting. That's really inconsistent and understudied. So what really motivated this first study was one that I conducted several years ago. At this point, I was a part of a team that looked at cognitive training in middle-aged adults. So these were healthy middle-aged adults. It was a pilot study of 14 people. We had two groups, cognitive training. They did this Nintendo DS. And you're probably like, what is that? Because they don't make them anymore, but I have used this for several studies. It's a handheld cognitive training, kind of like a Game Boy, if you remember what those are, where you use a stylus and you actually play the game on this little tiny computer-like device. And we did a crossover design. So half of them did cognitive training first. The other half did an active control. And it was a trivia control where they just answered questions on the computer to kind of control for that engagement as well, without targeting specific aspects of cognition. So they did the dosage for 3 hours a week for 6 weeks, and then they did the same dosage for the trivia control. So crossover design is good because it allows you to really capitalize on a small sample size. So this is what we found. This was published in Games for Health in 2017. And what I'm showing here, the blue is our proportion improvement for those who underwent the cognitive training. And then the orange is the trivia control. And the stars here indicate where there were significant differences between cognitive training and trivia control. So you can see here that we have 3 stars. So 3 areas of functioning where there was greater improvement in cognitive training relative to trivia. So executive attention, anxiety, and depression. So this is interesting. And we thought, well, maybe these are related. Maybe one of the mechanisms that's driving the cognitive improvement is related to this anxiety and depression. So we did an exploratory analysis where we looked at the associations between the reductions in anxiety and depression and the improvement in your cognitive domains. And we looked at this for the cognitive training and the control group. What we found was there was only one significant association. So reductions in anxiety related to the cognitive improvement on executive attention was significantly associated for the cognitive brain training condition only. We did not see this for the control group. So this is really interesting. And like I said, really kind of spawned this whole area of research for the past few years we'll be discussing today. So this previous study showed that this cognitive training does have transfer effects on cognition because we found it outside of the game. It was a neuropsych battery that wasn't trained in the game, and it looked to be related to reductions in anxiety. We know that insomnia disorder is considered a disorder that's related to hyperarousal and increased anxiety. We also know that cognition and sleep interventions have largely been investigated separately. So current sleep interventions, a lot of the people here, I'm sure, are familiar with CBTI, potentially are providers of CBTI as well. We know that it's hard sometimes to reach people and provide them with access. Other treatments that are currently prescribed are medications, and we know that they do not have long-term efficacy. So there is still this need to look at other potential adjunct interventions that might also help sleep and cognition. So only 6 studies have looked at cognitive training effects on sleep. There'll be more once the current work is out there as well. So we're currently conducting a systematic review looking at this. And what we've noticed that there's really a lack of RCTs with active control conditions and really controls in any regard. There's also a lack of studies in patient populations. So insomnia, mild cognitive impairment, we're not really seeing that. There's also a lack of studies examining different aspects of sleep, so objective sleep. Also lack of studies examining arousal. And as I alluded to, potentially arousal is a potential mechanism that might lead to improvements in other areas of functioning, not just cognition, potentially sleep. So really what we don't know and what we're trying to figure out is potential mechanisms by which cognitive training might improve these other areas of functioning. So this is the conceptual model that I talked about that I'm currently testing. So we're really interested in looking at this cognitive brain training and looking at it on various outcomes. So sleep, cognition, both subjective and objective, mood, and then also potentially looking at these mechanisms of change. So looking at arousal, looking at sleep architecture. Down the line, I'm not presenting today, but looking at cortical function, cortical plasticity. There's also this aspect of moderators that might impact the effects of these mechanisms on our outcomes. I won't be discussing that today, but those are areas for future direction. So looking at how engaged they are, looking at what exactly you're training. The first study is a Focus Project Award. It's currently in prep, so will be submitted soon for publication, and it's called PLAY, so Pilot Study Evaluating Playing Games, Cognitive Games on Cognition and Sleep in Older Adults with Insomnia. So we were interested in this cognitive training intervention that we were going to deliver for 6 weeks relative to a waitlist control. I will say this was conducted during COVID, so we had to change things up a bit. So we did a crossover design with the waitlist control. So we were interested in looking at the efficacy preliminary on cognition as our primary outcome. And we did expect it to improve cognition, potentially self-reported and objective. And then we also looked at sleep, arousal, and mood. So I won't go over all of these specific metrics here, but I can definitely answer questions on that later, but I will present the primary results. Okay, so our older adult participants were 60 years of age and up. They had insomnia disorder. So again, it was that chronic disorder. We confirmed this with sleep diaries as well. They were cognitively healthy. They didn't have any major medical or neurological disorders, and they were stabilized. If they were on sleep meds, they were stabilized for at least 6 weeks. This was Big Brain Academy. I've since moved on from that since they don't make it anymore. But at the time, we started this in late 2019. It was a crossover design. So again, half of them did cognitive training first, did their baseline post-cognitive training assessments, and then the waitlist control. And the other half did the reverse. So crossover design, we were able to kind of control for carryover effects and also combine across participants. So our cognitive training dosage was the same as the previous study. So it was 18 hours total, divided up by 60 minutes, 3 times a week for 6 weeks. And I noted this here, we asked them not to play within 2 hours of bedtime just because of some recent work that suggests that that may actually interfere with sleep. So I'll just put the measures here. We had different domains. We did cognitive training. They did the NIH toolbox. They did some computerized training as well. We did the Stroop. We did a Sternberg working memory task. For sleep, we did 1 week of diaries assessing SOL, WASO, total sleep time as our primary outcomes of interest. We did the ISI. They did actigraphy as well for 1 week, looking at the same variables as our diaries. They also did the PSG sleep profiler for 1 night, and that was for budgetary purposes. And so we looked at the same variables as sleep diaries and actigraphy, and then we also took a look at sleep architecture. So percentage of stage 1 up to N3, and then percentage REM. For arousal, we did self-reported, so the pre-sleep arousal scale. And we also looked at heart rate variability as a measure of physiological arousal. So that's a really non-invasive, easy way to measure physiological arousal. And basically, it gives you an index of the functioning of your autonomic nervous system. So spoiler alert, there is no results for arousal in this particular study. Other studies, we did find results for arousal. But if you have high heart rate variability, that's usually a good thing. And then we also looked at mood, depression, and anxiety. So here's as our consort. We had 12 participants in each condition order. So dropout was really good, actually, really, really low. And like I said, this was conducted kind of in the heyday of COVID. So here's our participants, our ages. We tried to randomize, but they were a little older in cognitive training. I did look at this on the outcomes, and it had no impact. As with most of these insomnia studies, they were mostly women, and our ISI, they were above the cutoffs, around 11 to 12. So our results. So we found that cognitive training did improve certain aspects of cognition more than our waitlist control. And this was in immediate verbal memory and working memory. So what I'm presenting here is our collapsed across participants, our baseline in black, blue is post-cognitive training, and our gray is post-waitlist control. And we found that we see this jump in auditory verbal memory from baseline to post-cognitive training. And this was almost a moderate to large effect. And then we see this trend where it goes back down after the post-waitlist control. I'm not as worried about the trend because, like I said, we're part of that could be a carryover effect for the people that did the cognitive training first. So we're gonna delve into that a little bit deeper. But just seeing that is definitely good news. We see a very similar pattern for the Sternberg working memory. We're getting that increase post-cognitive training, and that was a moderate effect. And then we're getting that significant decrease back down after the waitlist control. So again, that's suggesting that it's over and above just practice effects in the waitlist control. For sleep, a little more inconsistent, but definitely some promising and novel findings here. We did find that cognitive training showed patterns towards more WASO, TST, and SOL improvement, the waitlist control, but it depended on how you were assessing it. So for our diary, we found this decrease from baseline to post-CT, about 24 minutes. And that was a moderate effect. The difference here between baseline and post-CT, post-waitlist control was not significant. But again, if you look here, it's starting to go back up, but it doesn't change there either. So there's a caveat there when interpreting it. For actigraphy, for TST, we did find a significant increase from baseline to post-cognitive training. And then again, this trend where it goes back down post-waitlist control. And that was a moderate effect. We did not replicate the TST for PSG, but again, like I said, 1 night. So we need to collect more data in future trials. We did see this improvement from baseline to post-CT, but we saw the same thing for post-waitlist control. And our effect sizes were basically the same. For PSG, sleep onset latency, we did find a decrease here from baseline to post-CT. And then again, we're seeing it kind of go back up post-waitlist control. But we do find a significant difference between baseline and post-CT and post-waitlist control. So we go to the effect sizes here. We do find a greater effect size, a larger magnitude of effect size for post-cognitive training, large here, versus our waitlist control, which would be moderate. So again, promising data. Okay, so overall, partially consistent with our hypotheses that cognitive training does improve this non-trained cognition. It does not extend to self-reported cognition. And again, our group was older adults with insomnia. Partially consistent with what we predicted, cognitive training may lead to better sleep in this patient group as well. And based on what we were finding, it could be that it's potentially facilitating sleep onset and maybe reducing how much time you're actually awake. So it could be improving sleep consolidation as well. So in the future, we're going to look more into this, looking at mechanisms underlying this improvement. We didn't find anything for mood and physiological arousal in this patient population. Overall, although preliminary findings could promote cognitive training as a potentially easily disseminable behavioral intervention, potentially used in conjunction with other first-line treatments, relaxation, CBTI, things like that. Limitations, it's a small sample, one night PSG, and we used a wait list. So we need to use active controls. Future directions, I'm not going to go into these for the sake of time. Happy to discuss after the talk or offline. We have a lot of future plans and a lot of data mining to do with this data where we'll look at other PSG metrics. We're going to look at individual characteristics, potential moderators of impact, and then combined therapies as well, interventions as well. Okay, so in terms of our conceptual model, we have to consider these in terms of our moderators, which are the patient groups, but in terms of older adults with insomnia, we can kind of start to take out ones that we might not be impacting. So maybe it's not self-reported cognition, maybe it's not mood. I feel wary to take out arousal here because we really need to look at nighttime arousal and other metrics of arousal as well. Okay, so study 2. Study 2 was another study funded by a Focus Project Award. And this one's looking at sex differences and sleep-related attentional biases. So I do a lot of work on sex differences, and I'm just going to give you, like I said before, a few statistics here to kind of get you primed for this talk. But there are known sex differences in prevalence of sleep disorders and cognitive impairment. So insomnia is more prevalent in women, 2 times more prevalent. Potentially hormonal changes, specifically at midlife, could be a contributing factor. Women are also more likely than men to report multiple sleep symptoms. Okay, so multiple of these. And then men are more likely, 3 times more likely than women to report snoring, sleep disorder, breathing. And this is a really interesting statistic here. In men, OSA is associated with a 2.5 greater risk than women in developing Alzheimer's disease. Again, we need to determine which cognitive domains might be affected, but that's still a pretty alarming statistic. So we know there are also known sex differences in cognitive function. There's a few. Verbal learning and memory and psychomotor speed are better in older women versus men. And visual spatial ability is better in men than in women. Women also have a higher prevalence of non-amnestic MCI. 2 times more women than men have Alzheimer's disease, which is one of the, it's one of the things we're trying to figure out. We still do not understand the exact mechanisms that are underlying this statistic. And it's not just due to women live longer. There's other things that play here, and sleep might play a vital role. So in non-demented older adults as well, women show faster decline in global cognition and executive function. So it's not just the ones that show the pathology and actually the neurological disease. Even when they're non-demented, we're seeing this increased risk for women. We'll say some research suggests that there are no sex differences in the slopes of memory trajectories, which again suggests that we need to look more broadly at cognition, not just memory. So it's important to examine sleep and cognition in a sex-dependent manner. As I alluded to, we know that there's this association between sleep and also Alzheimer's disease risk, but also Alzheimer's disease pathology. So there's a few mechanisms that are currently being researched. The lymphatic system clears amyloid beta buildup, and that's a system that's very active during slow wave sleep. Sleep may also protect against neuron synaptic weakening. Okay, so if we can understand sleep and potentially the sex-specific way in which sleep might impact cognitive function, we can really get somewhere in knowing, sex-specific targets that we might need to look at for men and women as they age. Okay, so sleep-related attentional bias. You may know what this is. This also may be new for you, so I'm going to take a minute just to explain it. So there's this thing called the attention, intention, effort pathway, AIE pathway. It's a cognitive model. So what it is it's this excessive preoccupation with sleep. And when you're occupied with sleep, you really pay attention to sleep-related stimuli. You're more quick to look at it and pay attention to it. So that's what this sleep-related attentional bias is. And what it does is it contributes to the persistence of symptoms. So let's think about someone that's having trouble falling and or staying asleep or awake, right? They have this attentional capture to sleep-related cues. They're looking at the alarm clock. They're also, hearing snoring and all the environmental noise. They're really susceptible to it. And what that leads to is these sleep-related cognitive effects. They have these negative thoughts, I'm never going to fall asleep again. They also have these negative valence sleep-related emotional effects where they're really upset by it, which also interferes with their sleep. So what this does is it increases their hyperarousal and their distress. And just paying attention to these cues can do it alone. And it's this vicious cycle. Okay, so just experiencing all of that just goes back and you have trouble falling and or staying asleep. So in terms of despite the high prevalence of insomnia disorder in older adults, studies investigating sleep-related attentional bias are really lacking in this population. So it's unclear as well whether the bias is just for visual stimuli. So I mentioned some of those like the clock and, looking at someone that's sleeping soundly and you're not asleep, or potentially more broadly, such as auditory stimuli. And this has implications for treatment because you want to know what you might need to desensitize. So this study, we were looking, aim one was to compare visual versus auditory related attentional bias in those with insomnia versus those without. And we predicted that people with insomnia would show greater attentional biases. But because of the limited research, we didn't have a prediction whether it would be greater for visual or auditory. Aim two was looking at sex differences in these biases. And this was our prediction. We thought because women have this greater prevalence, the sleep-related attentional bias might be the mechanism or one of the mechanisms that's driving this increased prevalence. So we expected to find it greater biases in women. So participants were 81 older adults, again, cognitively healthy, no major medical issues. They were stabilized on sleep meds. We looked at insomnia status, so the same as before. We're looking at the DSM criteria plus confirming it with sleep diaries. We did cueing paradigms. I'll show you schematics of those in a moment, and we used visual and auditory stimuli. So our choosing our stimuli was probably the most challenging part of this study. We had to further validate whether or not these stimuli were related to sleep. So we used pictures from the IAPS, International Affective Picture System, and then they looked like this. And we had people rate them. We had a pilot sample go in and rate. How much do you think this is related to falling asleep? Not at all. Falling or staying asleep, not at all or very much related. Same with our auditory. We programmed these ourselves based on what we were reading in the literature and just kind of surveying people to what they think is associated with having these issues with insomnia. And we had them rated as well. And then we chose our stimuli that way. So we chose the highest ratings, the ones that were most likely related to sleep. For auditory, these ended up being, not surprising really, we had snoring, heavy breathing, alarm clocks ticking, going off, baby crying, and dog barking. Those are some of the common ones that we used. And our neutral tones in both in the auditory, in the visual, they were just the ones from the IAPS, but in the auditory, they were pure tones, just a beep, and they varied in frequency. So here's what our schematic looked like. And, you know, if you're into cognitive psychology, I can spend more time on that later, but I'm just quickly kind of showing you. What we're interested in here is looking at the difference between these cueing someone and them responding to the target, so that reaction time difference versus not cueing them. And then you present some cues that are sleep related and some that are not. So here are our outcomes of interest. We're looking at visual and auditory valid cueing effects, so that reaction time difference between the cue and the non-cue, and then our visual and auditory invalid cueing effect. So sometimes it's valid, it's cueing them to the left or right, and they have to respond to the left or right, or you could cue them to the right and they have to respond to the left, and that would be invalid. So both of those are ways to measure how much you're paying attention to the sleep-related stimuli. We also use the dot probe task. It's very, very similar. You're just presenting the stimuli at the same time. So you're cueing them up and down at the same time and then having them respond to this target. So again, the idea is that you're going to react more quickly to the sleep-related cue if you have insomnia. So here are our participant characteristics. Oops, sorry. So we had more non-insomnia than insomnia. We're still going to collect a little more data on this, but their age, so we're seeing here, pretty well matched here. Their ISI, so definitely higher ISI overall in the insomnia group versus the non-insomnia group, but we're seeing a higher ISI in men, which I'll talk about later. And then they were all cognitively healthy. Okay, so here's what we found. So for the Posner task, for the visual valid sleep-related cueing, there was a significant interaction between insomnia status and sex. And that's what we're showing down here. For insomnia is blue, non-insomnia is gray. And again, if you have higher values on this y-axis, that means you have a greater sleep-related attentional bias. So what we found was that in men only, we did not see this in women. So just here, there was a larger trending cueing effect for those with insomnia versus without. You can very clearly see that, and we did not see that in women. We found a similar pattern for the visual invalid sleep-related cueing. So again, a significant interaction between insomnia status and sex. Here, though, we found that in men, there was a larger cueing effect for those with insomnia versus those without. So definitely similar to the one we saw previously, just the invalid cue. And then we also found there was a larger cueing effect for men than women with insomnia. So here we are seeing that difference. So men were just showing these larger sleep-related visual cueing effects. In terms of our auditory cues, we found different results. So for our Posner auditory valid cueing effects, there was a significant main effect of insomnia status for the sleep-related cueing, but there was also a significant main effect of insomnia status for the non-sleep-related cueing. Okay, so we found very similar patterns here. So for both, you can see these on the left here, we have our valid sleep-related cueing for the auditory cues. And on the right here, we have the valid non-sleep related cueing. And look, they look very similar. Insomnia has a greater cueing effect than non-insomnia. Okay, so we had larger valid cueing effects for both sleep and non-sleep related cues for those with insomnia, and sex did not matter. So what does this mean? So preliminary findings suggest that men with insomnia experience these larger visual sleep-related attentional biases than women with insomnia, contrary to what we actually thought. So we were thinking about this, and we're still thinking about it, but there's some suggestions in the literature that point to the potential influence of circulating testosterone to spatial attention. It could be something that's has historical relevance, so they're more likely to pay attention to things that are highly emotional and in terms of threat and valence. Okay, so it could potentially extend to sleep-related stimuli. So that's one potential explanation. Also, the severity of insomnia symptoms. So we saw that men, they had the higher ISI, so it could just be that as well. There could also be this potential habituation of sleep-related stimuli in women. Okay, because women are experiencing insomnia at 2 times greater prevalence, they usually also have a longer duration of insomnia, and that could be because they go to the clinic to actually get diagnosed. But that could habituate them, so they're less reactive. You're seeing less of a difference between sleep and non-sleep related cues. There's also this idea that they could be viewing the stimuli for women as part of the entire environment, and this could actually reduce the impact of the spatial cueing. Another thought that we are toying with is the contribution of other factors. So it could be that sleep-related bias is not the driving factor for insomnia persistence in women. It could be these other factors. And I've definitely looked at these in my lab as well. Physiological arousal, increased pain, hormonal changes, mood, higher order potential maladaptive thoughts. These are all things that are really prevalent in women, and that could be kind of taking over in terms of making these insomnia symptoms more severe. So the other point of the other main finding is that there could be this general auditory attentional bias in insomnia. This could reflect this general auditory cortex hypervigilance. So again, we didn't see that difference between sleep and non-sleep auditory stimuli. So it could be that the auditory system is just always primed if you have insomnia. So you're always going to react to anything, regardless of whether or not it's related to sleep. So overall, aging adults with insomnia, they might benefit from stimulus desensitization towards insomnia triggers across sensory modalities, and men may benefit more for visual desensitization. So if you took Intro to Psych, you would know what this is. It's classical conditioning. Stimulus desensitization is this systematic, repeated exposure to stimuli in non-threatening conditions. So basically, you're scared of rabbits. You like cookies. I'm going to pair the rabbit with the cookies over and over and over again. And eventually, when I just show you the rabbit, you're going to think of cookies, and you're not going to be scared of it anymore. So that's what stimulus desensitization could look like. And we could implement this using visual stimuli and rewards and incentives, potentially into graded exposure and relaxation into CBTI. Okay, so I think I made it. We definitely have time for questions. I definitely want to thank everyone in my lab and collaborators. I have tons of grad students, research coordinators, med students, undergrad research assistants that all helped conduct this research. And of course, AASM Foundation for all the funding and the support, and other funding mechanisms that support my lab as well. And that's all I have, and happy to have a discussion and take questions.
Thank you so much, Dr. Curtis, for the very insightful presentation. We did have a couple questions come through, and I just want to mention to the attendees, you are welcome to put in questions in the Q&A, and we can see which ones we can get through today, because we'll use the next 15 minutes to go through these questions. So the first one that you have is, based on preliminary results, how would you define and enrich a patient group that could benefit most from cognitive training? And then the second question is, would you need different cognitive training techniques to improve memory and insomnia separately?
Mm-hmm. So I'll take the first one. I have some insider knowledge because this is just one of 2 other studies that are currently being conducted. And I will say that the cognitive training results differ depending on the patient population. So in this one, it was older adults with insomnia, but they were cognitively healthy. So there is another study that we're doing that is MCI, so mild cognitive impairment patients with insomnia, and they're showing different results in terms of their improvement on cognition and sleep. And in that case, we used an active control. So what I think is that the people that could most benefit are the ones that are most impaired up to a certain level. There isn't a lot of research on dementia patients because it's really difficult to get them to follow the instructions over a consistent time frame. But at MCI, we had a few safeguards and additional kind of check-ins with them, but they were actually able to do it throughout. That one was an 8-week program. So hopefully we'll have this kind of data out there, but I do think a lot of the cognitive training research is done in non-patient populations. So there's the ones where you don't really need to move the needle much, and even if you did, it may not manifest in a cognitive improvement that you would see objectively. Same with sleep. You could use the same type of logic to look at sleep. And then the second question.
It was, will you need different cognitive training techniques to improve memory and insomnia separately?
Yeah. So potentially, what we're going to be doing, this study actually showed that it did improve memory selectively. But what we're actually going to be doing is doing some data mining and going in to look at what they actually trained on, because I didn't mention this, but they were allowed to train freely. They just had some stipulations where they had to do one of the games where it trained everything at least once. But other than that, they were kind of free to explore the game and play different games. It does, in some of the subsequent trials, it does challenge them on the ones where they are most deficient. So it will tend to give them the games that they are struggling with. So we're going to go in and do some association type of moderation analyses to look to see if they actually trained on a specific task, did that lead to more improvement in cognition and sleep. So I will say I'll get back to you on that one, because that we're going to do some secondary analyses to look at that. But I would think so. In terms of our patient outcomes, where it differs by group, I also think it differs by what you're actually having them train on.
Thank you. So we have another question from James Gentile. His question is related to the types of training being used for these cognitive training programs. And his question is there any research on using specific training programs versus just using your brain consistently, such as reading, learning a new language, etc.?
Yes, there is. So, and again, we're also looking at this. Game engagement is a big factor here. So often when you're having someone do a strategy that's very much internally generated, that's more difficult to do consistently over time. If you're having them play the game, it's not that it's passive, but it's showing them a game and they're playing it in the moment, and it's challenging them and they find it very engaging. And I didn't present the data today, but we do have some data that shows that if they are more engaged in the game and they're reporting that they enjoyed it and they were, finding it challenging, they actually had better improvement in cognition. So that is one of the factors in game design, and why it's popular is because it's popular. People like doing it. As you saw, we had pretty low attrition because people enjoyed doing it at home. I will say that there in some patient populations, if the task is too challenging, and they get frustrated with it, not just with the technology, but with some of the instructions in the game, that can hinder performance. So we're actually developing our own. We're kind of starting from the ground up to develop one that considers all of these factors in the actual game design. Yeah, I hope that somewhat answers your question.
Thank you. Other question, very easy, is which Nintendo game was used for the studies? I know you had mentioned it was the Nintendo DS,
Yeah.
and it was potentially discontinued, if I recall correctly.
Yeah. We use Big Brain Academy. So it's a game that trains a bunch of different cognitive domains. So you have this like little professor and he gives you instructions, and then you do the games with the stylus. So it actually does have kind of a 3D component to it as well, because you're actually using the stylus on the Nintendo game. Some of my other ones we're using more modern. We're using Cognifit, which is a computerized web-based version, and it's a little more modern in terms of its graphics, and it has a lot more diversity in terms of how many games you can play that target and train different domains.
Thank you. And then the other question that we have is, did you find that the cognitive testing increased anxiety and worsened insomnia in the subset? Specifically, this individual has an example that they found that some patients become more concerned about their cognition when they take cognitive tests.
Yeah, exactly. So, surprisingly, the means turned out okay. If you go and look, in terms of their cognition, if you go in and look at some of the individual data and look at some of the comments, they were reporting frustration with some of the games and they found it difficult. It does depend, we're looking to see if baseline levels of anxiety might moderate that and individual characteristics and personality. So that's a whole other kind of area in cognitive training, is looking at these moderators, these individual characteristics that might change things. We have a study that was conducted, a follow-up study in mostly women with generalized anxiety disorder, and they were middle aged, and we have very different cognitive training results. And those were exactly what you said. A lot of the qualitative data was them being frustrated with some of the tasks. So in that case, you kind of have responders and non-responders. And I think it's very much driven by their perception of the tasks. And like you said, kind of related to their ability as well. Because in these games, I didn't go into a lot of the detail, but it gives them their score. So they can see kind of how they're improving week to week. And of course, anyone that does cognitive testing, when you give them the feedback, that can interfere with their performance. So more on that later, I think, when we kind of dig a little deeper into the data.
Awesome, thank you. And then I'll just do one final question. This is just a general question I always have all of our grant recipients, and then also just kind of thinking into the future and connecting it to the work that our clinicians are doing and seeing these patients. So how do you think these observed gender differences, specifically with obviously individuals with insomnia, potentially inform personalized treatments and strategies or interventions targeting these sleep disorders, like in the future? Like, what would you like to see what do you see in the future if you had a crystal ball?
Yeah. I mean, starting to do this now with this kind of this foundational work, but what I'd like to see is, I mean, I'm developing a novel cognitive training, but I'd like to see, when someone comes into the clinic, and if they're female or male, and if they have a specific insomnia clinical profile, they get this computerized intervention, right? We already know that CBTI, there's lots of digital interventions for CBTI. There's apps, there's web-based ones. They're usually a one size fits all, but there's lots of work going into optimizing this based on the patient characteristics. There's very few studies that are looking at sex. They're not really looking at differences between men and women. So this preliminary data could suggest that maybe for men, we need to put in a little graded stimulus exposure potentially into CBTI that could actually improve their outcomes. And there is some work that shows that there are sex differences even in CBTI outcomes, right? So, we don't see relaxation doesn't work for one sex, or we see differences in attrition and how engaged they are at different aspects of it. So what I would like to see is more individualized, personalized recommendations. But in order to do that, we need to first optimize the interventions and have them readily available. I think cognitive training and the stimulus desensitization are good because they don't involve the homework. You're kind of just doing it in the moment. And then even if the effects are smaller, you still get some kind of improvement in our cognition and our sleep outcomes. So potentially if you pair that with CBTI, which involves more engagement and homework, we could see even more improvement.
Great, thank you so much for answering that question. I think that wraps up the Q&A that we have for today. So again, thank you so much, Dr. Curtis, for taking the time to provide this very super insightful, informative presentation. And I'm excited to see your other work that you have coming up on the pipeline. So hopefully there will be a part 2 to the Sleep Grand Rounds,
Yes,
maybe
absolutely.
a year or 2 from now. So, and then yeah, thank you. And then obviously thanks to everyone who participated today. So for today's webinar, there will be an email that gets sent out with instructions on credit claiming. This webinar is approved for 0.75 AMA PRA credits. And then next slide, please. So this is actually the second Sleep Grand Rounds for the year for the AASM Foundation. The next one that we have will be in July after the sleep meeting. This will feature Dr. Justin Fiala and his work in starting up a free clinic in Chicago. And registration for this webinar will be available soon, so keep an eye out for that. Next slide, please. And then finally, exciting news, if you are attending the Sleep 2024 meeting next month, the AASM Foundation's OASIS returns to Sleep 2024 in Houston. So don't miss out on an opportunity on various educational and professional development activities, including an inclusive leadership workshop, ASM assembly meetings, lunch for sleep medicine fellows, and mentoring hours for students and early career sleep professionals. So make sure you take advantage of this amazing opportunity by scanning the QR code to register and learn more about our schedule of events. So thanks again, everyone, for joining us today, and have a good rest of the week.